At this time, I'd like to introduce our speakers for today's program. Matt Morrison is the Executive Director of Healthcare Operations at MGM Resorts International. He leads healthcare operations for the company's self-funded health plans and provides strategic direction for the company's employee health and wellness goals. He has more than 15 years of experience working with self-funded employer health plans, serving in varying capacities for both employers and administrators. And Matt is joined today by Nikki Buchanan, who is the PHM leader for Philips Wellcentive. And to read more about each speaker, please click the link to their bios below. Thank you, Matt and Nikki, for joining us today. And with that, the floor is yours.
Thank you, Rajiv. This is Matt Morrison. I want to start by thanking Healthcare Informatics for hosting this webinar and providing this opportunity, and also to Philips Wellcentive for sponsoring. We have, what I hope to share today is a somewhat novel approach, a unique approach, at least by an employer to implement a health plan to help improve both the quality and access to healthcare for our members. While I did see the attendee list today, and I saw that many of you are from many different aspects of the healthcare industry. So while not everything in this may apply to all of you, I certainly hope that all of you will be able to glean at least something from what we're able to share today. So the agenda is good. Primarily, I want to just give everybody a background on MGM Resorts, and then the healthcare plan that we implemented a few years ago, and then also the path that was followed to get there, and then most importantly, what everybody will want to see is what we were actually able to accomplish. As much as I hate to look at or talk about myself, I feel like I should provide some kind of introduction. So I have lived in Las Vegas now for 20 years, so pretty much my entire adult career has been spent here and in the healthcare space. I started working for a third-party administrator here, and the majority of our clients were large self-funded hotel casinos, primarily on the Strip and elsewhere. Las Vegas is a unique market in that way, in that it's dominated by a few large payers. And again, we're on a little bit of an island with a little outside influence. So it's an interesting laboratory for healthcare innovation. I was at that third-party administrator for about 5 years, and then due to changes in ownership, as third-party administrators often have, I was provided the opportunity to actually come to MGM, who was one of our clients, by folks that I worked with there. So that worked out really well for me. MGM has been a great company to work for. I thoroughly enjoy it, and they have not gotten rid of me yet, so that's a plus as well. Just as a brief overview of our company and our resorts, we currently have about 68,000 domestic employees. The vast majority of those are in Las Vegas, but we've recently expanded to National Harbor, Maryland. We have properties in Detroit and in both Biloxi and Tunica, Mississippi. We recently acquired the Borgata in Atlantic City, New Jersey, and in about 2 months, on August 24th, we'll be opening another property in Springfield, Massachusetts. So we have, while we're primarily Las Vegas, we have been expanding domestically throughout the country. 51,000 of those employees are in Las Vegas, and of those, a large portion are actually covered under their collectively bargained union plans. And so those that are part of my responsibility are the roughly 20,000 primarily non-union Las Vegas employees that are eligible and enroll in one of our 3 health plan options here. Just as a little bit of history, you can see that we have quite a few properties here. When I tell people I work for MGM Resorts, more often than not, people just think of the big green building with the lion out front. We did start there. That was a seminal event in the company. In 1993, Kirk Kerkorian opened the MGM Grand here, which made it the third time that he opened the largest hotel in the world, following the original MGM Grand, which is now Bally's, and then even before that, the International, which later became the Las Vegas Hilton. So that opened in 1993, and he had eyes on bigger things, and in the year 2000, the opportunity became available to purchase the Mirage Resorts, which included Bellagio, Mirage, Treasure Island, and then later on in 2005, we were able to acquire the Mandalay Resort Group, which included Mandalay Bay, Luxor, Excalibur. Monte Carlo, as it's displayed on this diagram, has actually now been rebranded to Park MGM. So we have properties that run the gamut or the spectrum in terms of the type of resort experience that our guests either want or can afford. We have run the spectrum from Circus, all the way to Bellagio and everywhere in between. So we have quite a variety of options. Also, the T-Mobile Arena. I would be remiss if I did not mention the home of our Vegas Golden Knights, our Stanley Cup participants, even though they didn't win. So go Knights, go! I wanted to make sure to mention them. So that's essentially our Las Vegas properties, and really the focus of the plan that we were able to build, and kind of the history of what got us to the point where we were able to put together this direct care health plan vision. Now, a key aspect of this vision is that it wasn't something that we had to devise here and then sell to senior management. The MGM Resorts senior leaders, our chairman, CEO, have always been very engaged in trying to improve the health and well-being of our employees and their families. So in our market in Las Vegas, it's been dominated for some time by a few large payers, and because of that, the reimbursements to physicians has historically been much lower in other markets. And I'll get more into the repercussions of that later on. But essentially, we wanted to see what we could do to help kind of overcome that, to improve the way that we identify, measure, and report and compensate quality health care, and then also from the patient side, restore accountability for their personal health, and then making sure that they had access to high-quality health care, and once they feel that sense of accountability. Now I have to acknowledge the Patient-Centered Primary Care Collaborative, where we did a lot of research around patient-centered medical homes, and based on that research, we determined that those were really the tenets that we wanted to follow in our efforts to improve the way that healthcare is delivered here to our employees. We wanted to have designated PCPs, so not just attributed. A key part of the plan is that when our members, our adult members enroll, that they need to select a primary care physician and they need to actively select them. Those primary care physicians need to provide enhanced access to care for their patients. It helps to make our members feel special, but at the same time, it keeps them, it helps them to get a cohesive level of care in one place rather than trying emergency rooms or urgent cares or other points, access points for care. We definitely needed integrated technology to help facilitate that care coordination. We wanted to make sure that we were on the same page with all of our primary care physicians that we're partnering with for for years and years we have had great healthcare data analytic tools, but it's all with us, right? So we can see trends among our population, but up until our efforts through this plan, there was no collaboration with the physicians to help close gaps in care. We just knew we had them. We have KPIs to cover the triple aim, really, to cover quality, access, cost, and then we recognized that based on our market and the fact that our primary care physicians, when we started this, were getting compensated about 65% of Medicare, that we needed to change the way that we compensate them. We needed to make it so that in order to keep their lights on, they didn't have to see 40, 50 patients a day, and that they were able to take their hand off the doorknob of the exam room while they're meeting with the patient and really make those meaningful encounters. So if we built a great plan and nobody joined it, then it wouldn't really do us a lot of good. So we definitely had in mind the incentives and then the requirements that we wanted plan members to have, and these are things that they have to agree to at the time that they enroll for this direct care health plan. We actually give them the lowest paycheck contributions. This plan is offered alongside another self-funded PPO plan that had been in place for years, and a fully insured HMO option. And so regardless of what this plan actually costs MGM Resorts, it's still offered to the employees at the lowest of the three different plan options. In addition to paying the least out of their check, they actually pay, among the three plans, they pay the least out of their pocket when they go to the doctor or utilize services. No deductible, low co-pays. We've kind of eschewed the consumer-driven health plan approach. We want to make sure that there's price transparency and that our members understand as well as possible exactly how much things are going to cost going in, rather than having sticker shock later. A huge part of the plan and a big reason for success is that we had the PCPs guarantee same or next day appointments for sick visits, and then less than 30-minute wait times for all scheduled appointments. And that's less than 30 minutes from the appointment time to when the physician actually sees them in the exam room. Another perk for employees that enroll in this plan is that they actually get another PTO day. And this is a day that they can either use to go see their PCP for a physical, or they can go golfing or do some other kind of either physical or mental well-being activity. Like I mentioned earlier, everybody must select a primary care provider, and then we actually have a health score that's provided in conjunction with the physical at the PCP's office, where members can earn credits to reduce their paycheck contributions. And I'll talk more about that in a little bit. Now, for this increased reimbursement and having a good volume of our patients funneled to them, we're asking a lot from the PCPs, and then also providing some really good incentives. So again, kind of borrowing from what we learned from the Patient-Centered Primary Care Collaborative, we implemented monthly per patient care management fees, so regardless of whether the members of their panel actually see them, we'll still pay them a certain amount per month. This is to help cover the admin expenses related to updating the data systems that we put in place. Also, it helps to cover proactive outreach to help close those gaps in care. And we implemented global visit fees. So rather than a pure fee-for-service model where we're paying a little bit more for a 30-minute visit than we are a 15-minute visit, what we did with these physicians is we said, okay, if they're in your office, you take as much time as it needs to take, and we'll pay you a flat rate regardless. And we're not going to pay for each individual widget along the way. We're not paying for, the urinalysis dipsticks. We're not paying for EKG. If they need it, do it, but it's all part of this global visit fee. So it's not quite pure fee-for-service, and it's not capitation, but essentially somewhere in between. In addition to those two compensation elements, we have two bonuses. When we were developing the bonus structure and actually working with some prospective PCPs to put it together, we really wanted to be able to provide tiered bonuses based on how those PCPs performed compared to every other PCP on the plan. The PCPs agreed with that, but then they also wanted to know for sure that they would be able to receive some kind of bonus if they hit certain benchmarks that we lay out for them. So we actually finished a couple months ago delivering the benchmark bonus checks to our members, our PCPs. It's based on a certain dollar amount per member based on the number of members that they had in their panel during the year. And then the peer comparison actually has a higher per member rate if you finish in the top quartile next to your peers, a little less than that if you're in the second quartile, a little less than that if you're in the third quartile, and then no bonus if you're in the fourth quartile of the peer group. So we talked about the same or next day sick visits, so this would be, instead of an incentive on the member side, it's now a requirement on the PCP side. We have a dedicated kind of bat phone line for direct care patients to call so that the front desk person answering at the office knows that this is a person covered by direct care and that they should receive that enhanced access. And then we've provided tools for them, for population health management tools, referral platform that they need to utilize. And then we boil, our analytics team here boils the claims cost data, our survey data, the referral data, and the population health management tool data into monthly reporting packages that I'll review in a little bit, and then we deliver those monthly, and we want to make sure that those are actionable. So if we're telling them that they are lower than their peer group for mammography screening rates, then we let them know who in their panel is overdue at the same time. So the plan technology was a huge element of it and really is the backbone of this direct care health plan program. Without it, there would be no way to really hold the PCPs accountable for their performance. It really informs, again, that peer comparison, bonusing, and provides the incentives on both the PCP and the member side to get the kind of outcomes that we're looking for. So we currently have 29 primary care physicians throughout the valley. We intentionally keep that number small to make it manageable, and then also to make sure that each PCP has a meaningful number of our members so that they're not completely schizophrenic as they change from one payer's patients to another. We want to make sure that they're seeing a good volume of our members and that the office staff and the doctor can get into a good routine on exactly what needs to be done for our members. Those 29 PCPs presented a little bit of a problem, though, because we did not go with just one group. We actually focused on smaller to medium-sized groups where that incentive structure that I outlined earlier would have the greatest effect. So we have 19 locations under 17 different physician organizations and 16 instances of 9 different EMRs. So we really needed something that would work in a variety of office environments. And so we went with a solution that had an EMR agnostic approach that could interface when the EMR is willing, but then would also be available if the PCP was in an office where they needed to enter the data separately. when we went through the process of selecting that solution, we actually again included the PCP and their staff, and then the greatest determining factor in which platform we used was actually based on their feedback and the system's ease of use. And another key element that went into our selection was, this is a unique case. These types of population health management tools aren't usually sold to employer payers, but to healthcare systems and provider practices. So we needed someone that was willing to tweak their solution as needed to help fit this unique use case. Now, this is the monthly scorecard that I referred to earlier. You'll see the most important element and the first place that our PCPs go when they receive this report is that PCP peer ranking in the upper right corner. It's the measure on this report that drives the single most positive outcomes for our members. I've always said that we should just tell every PCP that they're ranked number 2 because that's the most motivated PCP in the group. You can see on here that we give them a variety of measures. Some are just informational and some of them actually have goals attached. So we look for certain survey response rates, survey satisfaction rates. What we have been calling registry usage is actually usage of that population health management tool. And then the scorecard completion and other kind of utilization metrics. So even if they're not working towards a goal, they're able to see where their performance compares and to the other PCPs in the group. So this section is what we're typically refer to as the operational portion of the scorecard. The bottom section gets into cost, where we actually show them the average cost for their paneled members, not only for the cost inside their office, but then everywhere else as well. We didn't want PCPs to be incentivized to just refer patients out in order to keep their in-office costs low. We want them to be mindful of the total cost of care. So we give them the total medical and RX expense from the various categories, and then actually provide them a risk-adjusted cost index. So if their panel is actually a higher risk, as it is in this sample case, based on age, gender, and prior diagnoses, then we estimate what the expected cost would be on that, based on that risk, and let them know how their actual costs compared to the expected. So in this sample case, this doctor's costs are actually run about 90% of what we'd expect. And then the bottom portion is where we provide what we consider more the quality metrics: cancer screening rates, diabetic screening rates, diabetic control rates, and then we highlight areas where they could improve in yellow, and then this cover sheet is followed by 20 plus pages of patient level information outlining who's overdue for what and what needs to be entered. On top of this, we have a health score program. So at the outset of the rollout of the direct care program, almost all of the onus for patient care was put on the PCP, and we measured their performance in that regard. We recognized that we needed to also put some onus on the members and motivate them to really engage with their PCP on improving their health care. We adopted a very simple 2-page scorecard based on biometrics and labs and vitals that are actually gathered during their physical with their primary care physician. So previously, 10 plus years ago, we had implemented a similar kind of health risk assessment where we kind of funneled all of our employees into this kind of fair where they were poked and prodded and measured and ended up with a score on the back end. But If they identified that they had high blood pressure, then it was, okay, sir, you have high blood pressure, you need to go see a physician about that, and then the onus was on them to take care of it. What we really like about the Health Score program is it's through a meaningful encounter with their primary care physician. If any risk factors are identified, they can work on how to mitigate that with their physician. The physician can then motivate them on steps that they need to take or should take in order to reduce those risk factors. And then we actually have a mechanism to where the physician can refer those members into additional health coaching, which I'll talk a little bit more about later. But the score is very simple. It's on a 100-point scale. And if they score well above 70, then they get $20 per check just for doing the score, and another $20 for a score above 70. If it's below 70, then they can still earn that additional $20 by meeting with our one of our on-site health coaches at least 6 times during the year. Now, this is based on, that incentive structure is based on the guidelines provided by the EEOC as they're related to ADA and ACA. That may be subject to change, so we'll be watching that closely. But we hope to be able to, if we need to, just tweak the incentives while keeping the health score in place going forward. And after Nikki gets a chance to tell you more about the path to transformation, I'll come back and tell you, for the number junkies in the crowd like me, I'll be able to tell you some statistics and measures about what we're able to accomplish. So with that, Nikki, I hand the reins over to you.
Thanks, Matt, and way to leave them in suspense for the next part. Good job. So as Matt has described, we have been on a journey together with this partnership with MGM in achieving their goals towards value-based care. And we thought we'd take just a few minutes and share a little bit about how we go through that journey. We like to apply it to a simple transformation model that many of you are probably can relate to in many ways, depending on where you are in your journey from fee-for-service, possibly to pay-for-performance, all the way to fully capitated type plans or shared risk and capitation type plans towards value-based care. And many of you are probably thinking, well, I've got tools available to me that help me, but they only take me so far. And it's challenging to align the tools, the data, the clinical workflows towards a reimbursement model that leads to ongoing revenue. So we like to talk about the transformation. We like to partner with our customers on that transformation, evaluate where they are, and then pick specific programs that allow their populations to navigate through an ecosystem towards change that specifically gets towards those revenue and clinical workflow improvements. So the prescriptive way Philips Wellcentive likes to tackle it is we say, we help you understand your population. Many of you have EMR platforms across your network. Often they're not the same EMR from place to place. So we use an agnostic approach to bring that data together and make meaningful use of that data. Once you have the data in stratified form based on high-risk patients, medium acuity patients, or low-risk patients, we help partner with you to navigate the right care plans, whether it be care management, care coordination, care assessment, care navigators, and actually plan with you the right types of patients or cohorts to activate into long-term care solutions, whether it be at the home, virtual care solutions, or just continuing on the journey of their wellness path in being proactive with getting them into the office for all those immunizations, yearly physical type exams that we know as patients are being monitored improves the outcomes if we're touching base with them on a routine basis. So this model is just a sample of the way we like to see our customers move through that journey. And I think you're getting a good story here today of the changes and improvements that he has shared with his own success. And, of course, he'll get to the good details in just a moment. What's important, though, when you select a vendor to help bring all of this data together and drive towards that clinical transformation that leads to revenue and reimbursement is there are things that class, even in the industry today, has recognized across vendors, such as ourselves, that allows you to find the right partner to work with your EMRs, to work with the chaos in your EMR environment, and bring all of that together for meaningful use and meaningful action. So we like to say we are all about the aggregation of the data. We believe you have to have something that allows you to do the risk scoring and risk stratification. You need to understand your clinical and financial performance. Matt's scorecards are extremely effective. Based off the data that he's showing, he's meeting the clinical needs of his clinicians, but he's meeting the business needs of his business as well, with the health plan specifically. We believe you have to have some form of care navigation or care coordination functionality, and that's really where the rubber meets the road, because as you take action, that information needs to make its way back into the EMR so that you can have that long-term longitudinal record that we know isn't necessarily based in the EMR episodes today. Of course, once you've got the patient stratified and you know the right types of activities in clinical care paths you need to deliver, it's important you continue to engage the patient in the right way, whether it be at their home or through annual visits or monitored care through chronic care visits. And of course, more than anything, as we're serving our healthcare system needs or our health plan needs, we've got to keep the clinicians engaged. And we can do that best by having that patient loop and that patient feedback on the outcomes that we expect to see as we provide the right care. So we're aligned to the Class 6, and we believe that any vendor that is chosen out there should meet all of that criteria for a successful population health journey, especially when you're taking on value-based care and risk contracts. We do it with a slightly different approach, possibly than others. We take the data that comes from all of the various EMRs across the areas. Matt mentioned, I believe, 29 different variations of providers and about 17 different EMRs. We bring that data together to provide the right insights needed to make those critical care gaps acknowledged and meet different levels of performance to achieve the closing of those gaps. We help deploy with our customers the right scalable care management programs, and of course we look for all the opportunities where we can engage the patient and the provider together in that long-term plan of care. And of course, any typical population health solution has to have some form of ability to talk directly back to the payer through outbound submission files, through reporting, through submission for CMS or government Medicaid type programs. And this is especially important when you're dealing with advanced payment models like ACOs, which many of our customers are in some form of an ACO type agreement or an advanced payment model agreement. So we thought we'd share just in a final slide before we turn it back over to Matt, what's our typical approach through implementation. We do spend a lot of time aligning the business goals. We do that through, of course, discovery. We use any previous KPIs that a business has had. We do thorough needs assessment of where we want the attention to be focused within the interfaces in particular. We look for those data feeds or those data points that will bring the most value to the most at-risk populations so that we can provide care quicker, faster, rather than waiting for them to come to us. So we align with our partners to set up their programs that way. And then, of course, we activate the programs, get the programs in place for yearly submission, payer reimbursement opportunities, or even those CMS-type programs. And then, of course, we work together with our partners each year to plan the next opportunity or the next cohort, the next chronic disease management program to put in place. It can be iterative throughout the year, or it can be done on a yearly basis. But our entire goal is to bring together the business transformation requirements, align those to revenue opportunities for our customers, and help create the right clinical pathways and clinical workflows for our customers to be successful. So they can do things just like Matt's doing today, which is managing successfully over 58,000 patients or employees in his network and continuing to expand that care to various regions within his business environment. So thank you for letting me share a little bit about the how. I'm going to turn it back over to Matt so he can share the really good details about the outcomes and the success he's seeing. So Matt, back to you.
Great. Thank you, Nikki. So let me get to the good stuff. I'm a bit of a numbers junkie, so this is where I live. So key results, specific to the health score. So the health score is a little bit interesting in that when we rolled out the direct care program in 2012, we actually had a hard requirement to receive an annual physical from your PCP, and if employees and spouses did not receive that physical, then they were not eligible for the plan the following year. Now, the EEOC guidelines didn't really fit with that. So what we've done instead is implemented the credits that I talked about earlier for the health score, but if you don't get it, you can still remain on the plan and just pay more. So in light of that, we were able to still get 85% of eligible members to get that health score and earn the participation credit. Of those, the 75 also earned the outcome credit. Or 72% also earn the outcome credit, and that was either by getting a score above 70 or by meeting with the health coaches. And among our direct care members, so the coaches actually are able to, all of our employees, whether they're union and not even in our health plan, or in a PPO plan or HMO plan or direct care, they all have access to the coaches. But by implementing this health score in the direct care program, we're able to increase that coaching utilization by 2.5 times among those direct care members. And then we were able to see the impact of that coaching, looking at those that had coaching in 2016 and got a 2016 score, and then looking at what their 2017 score then was, we were able to see that an 8.2 point improvement on average in their health score. Now this, on a cost basis, equates to about $350 per member per year just for that 8-point improvement. So we're able to see solid ROI based on those coaching efforts. The overall cost under direct care is now lower than our PPO plan in all three major categories: inpatient, outpatient, and pharmacy. Inpatient was the first to start beating the PPO plan, and pharmacy was shortly after. Outpatient, we honestly didn't think would ever get less expensive because we're improving access to primary care physicians, we're encouraging preventative screenings, and all those things cost money. But even in light of all of that, we're now less expensive in all three categories. A large part of that is due to fewer ER visits, fewer inpatient days, and then a better generic dispensing rate by working proactively with the primary care physicians to improve those things. Our annual medical prescription cost inflation over the last 5 years is about 1.5%, which is actually less than inflation. Our PPO plan hasn't performed too poorly at about 4.5% to 5% a year. I think there's probably some employers that would like to have that kind of inflation on their medical spend, but the direct care trend has been 3 times lower. In terms of access, again, we're asking PCPs to provide same or next day sick visits, less than 30-minute wait times, and we get a ton of surveys back from our members, and 92% of those surveys indicate that the PCP has met those guarantees. And in fact, 76% report waiting less than 15 minutes to see their doctor. In addition to these results, we actually just a couple months ago added a question to the survey in order to get a net promoter score for each of the primary care physicians, essentially just asking how likely our members would be to recommend their PCP to family and friends. So we've had that question in place for 2 months now. We have about 1,600 results that indicate that the average net promoter score for our PCPs is about 86. So we're pretty happy with that, but I think once we add that to the scorecard and let the PCPs see how they compare to everybody else, that we'll be able to drive improvements with that as well. From a quality standpoint, this chart compares our cancer screening rates from January 2012, when we started direct care, to the end of last year. You can see significant increases in mammography, cervical, and especially colorectal cancer screening rates. We're especially proud of the improvement in colorectal cancer screening, as well as the cervical screening, because those are two that just by getting it can actually reduce the risk of cancer going forward. We also place quite a bit of focus on our diabetics. Initially, we were looking just to get the screenings done during the course of the year, and then as we've continued to improve our measurements and really just ask the primary care physicians for more, we started getting a little more qualitative with those diabetic measures, and have found that we've been able to get 78% of our diabetics with an A1C in good control and 81% with blood pressure in good control. And again, these are all measures where it's calculated into their rank, it's calculated into their bonus, and the primary care physicians are really motivated, for their own benefit, in order to improve these measures, and it works out for the patient. It works out well for us, for costs going forward, and it helps accomplish that initial vision that I mentioned earlier, is to really just improve the quality and access to care that our members receive, and then in improving the level of accountability that they feel in order to get, to treat their diabetes, to get their cancer screening rate, and to really look at their biometric measures. Another thing that I did not mention earlier is with our health score, we have those 6 main measures, but we were able to run a linear regression against costs to see which mattered most. So we're looking at blood pressure, cholesterol to HDL ratio, glucose, the waist to height ratio, and tobacco use. And interestingly, we found that the 2 factors that were the greatest determinants of cost were waist to height ratio and glucose. And so those are things that we're really focusing on with our on-site coaches in order to inform people about the effects of carbs and sugar, and the importance of the effects of metabolic disorder, and the importance of really managing not just weight, but weight around the waist, which is really increases those risk factors. Another key result is the adoption by the employees. When we rolled this out in 2012, we were able to get about 11.5% of our Las Vegas plan members. It's now grown to be the largest of the 3 health plan options that they have access to. And by growing the plan, we've added additional primary care providers, but we've tried to limit the number in order to provide them with a meaningful number of patients per PCP. So you can see that over the years that's grown from about 200 patients per PCP up to almost 700 now. So again, it makes it really worthwhile for these doctors to implement the changes in their practice, to really make the effort to do the proactive population health management, and make sure that these members have access to that quality care. Another positive effect is that some other employers and unions in our area have seen what we've been able to accomplish, and we're an open book. That's why I'm on the call sharing this with all of you now. And they've been able to also adopt some of the tenets that we have, and so we're starting to see really an improvement in the market overall in terms of the importance placed on primary care physicians and the importance placed on population health management. So with that, I believe it's time for questions. Rajiv, I think I'll hand it over to you.
Yeah, absolutely. Thank you, Matt, and thank you to Nikki for a really informative presentation. Like you mentioned, Matt, we've already had some questions come in for the audience, from the audience, but we would like to take this time to remind you to use the Q&A area below the slides, and you can still submit a question at any time. To download today's slides, you can click on the Resources tab to the right of your presentation window. First question is for Nikki from Philips Wellcentive. How do you get started on this path to transformation?
Great question. There's of course many different approaches, but it's so focused and dependent often off of the payer reimbursement model in your market. If the payers are looking for you to show quality and quality improvements, and that's where you can make the first gains towards advancing reimbursements and adjusting clinical workflows to meet those, then that's where we partner with our customers to start. Some of them are already in ACO type contracts, and so they ask us to focus on 13 to 17 specific measures of quality or measures of performance. So it truly just comes down to what is the goal of the organization, and it's usually that combination of a business goal, a program goal. Sometimes it's let's just focus on diabetics or chronic disease management, but it's that combination of business, programs, and clinical data needing to come together to find the right revenue and market opportunities. And that's why I mentioned earlier it's so important that we have account managers who work directly with these customers and get to know them intimately, and the programs not just in their local market but in their state, and then also federal programs, because we've seen a constant evolution towards more opportunity with chronic care management in certain states. We've seen reimbursement start to come in state by state and even nationally for telehealth and ambulatory care, virtual care. So it just truly depends on market, revenue, demand, and where the gaps are in clinical workflow or clinical opportunities. And once we assess that, it's very clear to us the kinds of plans we can put in place, whether it be 1, 2, or 3-year strategic plans with our partners and our customers.
Great, thanks. Well said, Nikki. Next question from the audience. What was the biggest barrier to this population health management work? Can you discuss how you overcame these barriers, or this barrier, and the clinical implications of it?
So that's tough to think about. I would say the biggest barrier is just, while high tech is required in most EMRs to be able to share data, it doesn't make them make it easy, right? We've been able to establish some direct interfaces from the EMRs directly into the population health management tool, but for the most part, there has been some double entry. So I would love to see more interoperability in the market. I think that would probably be the biggest barrier. The other would just be changing behaviors. I mean, that's always the hardest. In order to really improve our health and to make meaningful differences in our lives, it takes a long, concerted effort, and so that's why here at MGM we take the long view, and we know that it's going to take a while to make a meaningful difference.
I'd love to second those. Interoperability is going to be, I think, the long-term challenge as we bring together solutions. I also think, though, that beyond just interoperability, even when we get the data and we're making the right program choices and clinical workflow changes for revenue and reimbursement, it's still very important that that data gets back to the EMR. So, we've been faced with the past 2 years with now having multiple systems that our clinicians and partners are working on. So we have found partners ourselves that allow us to get that data directly back into the EMR, tapping the shoulder of the physician at the time of care so that they know exactly what those care gaps are. And I really think that's the evolution or revolution we should all be striving towards, because we cannot ask clinicians to continue to document in multiple systems. It degrades the care and the quality with patients. And then I would just say, kudos to Matt. I think he shared really great examples of the behavior change he's mentioning. Notice in the beginning he said they aligned the physician incentives directly to the model behavior that they wanted. So when you align the incentives, then you hold the clinicians accountable through scorecards, and then you pay them and reward them for the behavior that's asked to improve everybody and improve healthcare in general for that health plan. That's when you have the winning results. And that's what we see with our customers today. Those that properly align clinician engagement with financial incentives have the most immediate success and long-term success, especially when it comes to negotiating with payers in the future.
Yeah, well said, both of you. And while you mentioned EMR data, while we're on that topic, the next question from the audience is any claims data used, or is it only EMR data?
So the scorecard that each PCP gets and the portion that breaks down the average cost for their panel is from claims data. And then we have another tool that we use that gives us that aggregate risk score so that we can risk adjust those costs. In addition to that, I would be remiss if I didn't mention that Wellcentive worked with us so that we could not only feed in claims data to Wellcentive, pharmacy claims. We also have lab interfaces directly from our two largest labs here, so that another value of Wellcentive for these primary care physicians is they can see not just what's happening in their office, but then all the care and diagnoses and lab results that their patients are receiving from encounters at other offices.
So yes, I concur. Claims is a critical part to having the full data picture, but it is just one component. As Matt is mentioning, there's several others. Some customers of ours take the approach of claims only. They're willing to work with the fact that the data is sometimes 90 days old, if not longer. But many of our customers say, please combine the information we get from claims with our clinical data, with our lab results data, because that's the important thing to have the full longitudinal record for these patients. And I also just second what Matt says about long-term, even referral patterns have become a major request of our customers and partners these days. If we know where our patients are going, if we know they're not staying necessarily within our network or going to the recommended providers that we know drive the most value or care, then we need that data so that we can get ahead of that, in front of that, and steer them to the right providers in the network. And so we see that opportunity to continue to share those data points specifically towards the right form of referral management and referral patterns in the future. Because if you're going to control your costs, you've got to know where your patients are going.
Great. I think we have time for one more question before we close. The last one from the audience. Do you look at any of the metrics split by adults versus pediatric, or any pediatric-specific metrics? And as a follow-up, have you noticed any trends in the pediatric population? And would you expect that model to work similarly for kids?
Yeah, we haven't done as much on the pediatric side. It hasn't been as much of an area of concern. Our focus this year, going into next year, is actually enhancing our programs around maternity management and ways to mitigate some of the cost of care around NICU babies. And so there is kind of the gap in between maternity, neonate, into pediatrics that we haven't addressed as much yet.
I would add from our other partner view, our customer's view, we do have several pediatrics customers that do apply specific measures, specifically around diabetes, asthma. There's many opportunities to see these rising risk populations happening in the pediatrics world, especially as they're moving out of adolescence into adulthood. And a lot of our partners will use programs and this data that they get from Wellcentive to decide what types of programs to set them up for long term. And regarding Matt's comment with the NICU babies, that's another area where we continue to see requests from our overall Philips customer base, because they know we have the data within the health system about what's happening with these babies, and what they want is there any form of adaptive intelligence that we could apply to the future type of care for these premature babies, because that's often the issue. So we've invested in things like our UGrow app, and we of course are following the data patterns beyond just the inpatient stay to the ambulatory and out-of-hospital stays as well. So as Matt's described, he's got a very mature program running here, and it's only because he's had success with these programs that he's now able to look at some of these other opportunities and programs to tackle some of these rising risk situations. So I can't thank Matt enough for being such a well-running machine when it comes to value-based care and population health initiatives. He really is one of our model customers as far as attacking programs from a clinical and a financial perspective.
Great. Thanks to Nikki and Matt. Unfortunately, that is all the time we have for today's presentation.